What do you know about electroconvulsive therapy? First introduction. Electroconvulsive therapy, formerly known as electroshock. It was first introduced in 1938 by Italian neuropsychiatrist Ugo Saletti and DISHA and gained widespread use as a form of treatment in 1940s and 1950s. Next definition. Electroconvulsive therapy is the artificial induction of the grand mal seizures. Grand mal seizure for tonic phase for lasting 10 to 15 seconds. The application of the electrical current voltage 70 to 120 volts to the brain. The stimulus is applied through the electrodes that are placed either bilaterally in the frontal temporal region, in that tragus of the ear and lateral canthus of the eye, both sides bilaterally, or unilaterally on the non-dominant side. Parameters of the electrical current applied. Standard dose according to American Psychiatric Association 1978, voltage 70 to 120 volts or duration 0.7 to 1.5 seconds. Next, types of seizure produced. First, grand mal seizures, tonic phase lasting for 10 to 15 seconds and clonic phase lasting for 30 to 60 seconds. Next, mechanism of action. The exact mechanism of action is not known. One hypothesis states that ECT possibility affect the catecholamine pathway between diencephalon, from where seizure generalization occur, and limbic system, which may be responsible for mood disorder, bipolar, mania, depression, and others, also involving the hypothalamus to stabilize the neurotransmitters in the brain. Next, types of ECT. First, direct ECT. In this, ECT is given in the absence of the anesthesia and muscular relaxant. This is not a commonly used method now. Second, modified ECT. Here, ECT is modified by drug-induced muscular relaxation like succinylcholine agent and general anesthesia, thiopental sodium. Next, frequency and number of ECT needed. First, frequency 3 times per a week or as indicated, or total number 6 to 10 up to 25 may be preferred as indicated. Next, application of the electrodes. First, bilateral ECT. Each electrode is placed 2.5 to 4 cm above the midpoint of the on the lining, joining the tragus of the ear and lateral canthus of the eye. Second, unilateral ECT. Electrodes are placed only one side of head, usually non-dominant side. Unilateral ECT is safer with much fewer side effects, particularly those of memory impairments. Seeing the picture, unilateral ECT. Next, benefits of ECT. First, ECT relieve very severe depressive illness when other treatments have failed. Second, ECT has saved patients' life because 15% of people with severe depressions will kill themselves. Third, ECT works faster than all antidepressant drugs. Next, indications for ECT. First, major depression. Second, severe catatonia. Third, severe psychosis. Fourth, mental organic mood disorder or organic psychosis. And other indications, ECT is preferred to antidepressant therapy with cardiac disease when tricyclic are contraindicated, congestive cardiac failure for the pregnant woman, in whom antidepressants place the fetus at risk for congenital defect. Next, contraindications for ECT. First, absolute and second, relative. First, raised intracranial pressure or second, cerebral aneurysm, cerebral hemorrhage, brain tumor, acute myocardial infarction, congestive cardiac failure, pneumonia, aortic aneurysm, or retinal detachment. Next, complications of ECT. First, life-threatening complications of ECT are rare. Second, ECT does not cause any brain damage. Third, fracture can sometimes occur in elderly patients with osteoporosis. Fourth, in patients with history of heart disease and respiratory arrest may occur. Next, adverse effect of ECT. First, memory impairment, drowsiness, restlessness, poor concentration, anxiety, headache, weakness, dryness of mouth, palpitation, unsteady gait, tongue bite, and incontinence. Next, ECT team. For psychiatrists, next anesthesiologists, trained nurse, nursing aides, and ECT assistant. Treatment facilities: first waiting room, second ECT room, or third recovery room. Articles needed for ECT: first articles for anesthesia, next suction apparatus to prevent the aspiration of the and pneumonia, face masks, next auto cylinder for provide oxygenation, tongue depression to prevent the tongue injury or lips injury, next mouth gag to prevent the tongue bite, resuscitation apparatus or full set of the emergency drugs like atropine or defibrillator. Next, most important role of nurse in ECT: first, pre-ECT care, inform consent to the patient or the relatives or take signature in the consent, fully explain the risk and benefits of the procedure, and answer questions from the patient or their relatives. Next, information sheet or patient's anxiety and the help established to build patient-doctor relationship. Administration of drugs like atropine 0.6 mg/m, check patient's record, check the vital sign, check the empty bowel or bladder is or not, check the physical movement of the patient, explain the procedure to the patient or the relatives, keep patient on nearby mouth or 6 to 8 hours before ECT, discourage smoking just before ECT, remove artificial dentures and articles, jewelry, nail polish, or remove the hair oily or doing the hair shampooing. Next, ensure the emergency articles are accessible or emotional support to the patient or the relatives. Transfer the patient to the ECT room with the necessary records. Client educations before ECT. First, an instruct. Next, ECT room. Check patient's identify. Check patient is fast and has emptied their bowel and bladder prior to coming to the treatment room. Check patient is not wearing restrictive clothing and jewelry, dentures have been removed. Consult ECT record of previous treatment including anesthetic problems. Ensure consent from is signed appropriately. Check no medications that might increase or reduce the seizure threshold has been recently given. Check ECT machine is functioning correctly. During ECT, reassurance and support. Place patient in supine position. Necessary drugs administration. Preceding that atropine or next anesthesia succinylcholine is a muscular relaxation and anesthesia is a thiopental sodium. Mouth gag is for the prevent tongue bite. Next, during ECT, reassurance and support to the patient. Place the patient in supine position. Necessary drug administration like atropine, general anesthesia, thiopental sodium, and the muscular relaxation agent like succinylcholine. Mouth gag to prevent the lips injury and the tongue bite. Applied upward pressure to the mandible or oxygenation administration. Clean the scalp with normal saline or otherwise hair shampooing. Prevent fall, fracture and dislocation. Provide the side rails. Remove the mouth gag after seizure occurred. Suck the oral secretion and applied O2 mask. Post ECT care. Ship the client to the post-op procedure room. Check vital signs every 15 minutes. Administer drug if patient is aggressive, violent, or confused. Next, if respiratory difficulty, continue oxygenations. Provide side rails. Be with the client, documentation, and reorientate the client after recovering. Thank you.